so much for having me, and what an incredible new beat. I'm so happy that we're all part of the resuscitation of medicine with this new beat, so that there is more access to care to those who don't have it. And there's a lot of that here in the United States. And then importantly, in promotion of talent in medicine that is absolutely missed in the underrepresented minorities and women in cardiology. So thank you. And I'm just so profoundly proud of the Cardiovascular Research Foundation and ABC to take this on together in partnership, and really, really humbled to be standing here in front of my one and only mentor here, Dr. Marty Leon, and then of course to be in the presence of Stacy Rosen, who taught me cardiology at Mount Sinai when I was a child. So it's wonderful that we're talking about the high bleeding risk patient. Important for you to note my disclosures. There's plenty of them because of all of the work that I do with medical devices as well as pharmaceutical companies. And I'm really glad that you covered this topic, because it is really not, it's been sort of the year of the high bleeding risk, but very, very important about the fact that we focused for the last 3 decades on the ischemic complications. And what we're doing in many, many aspects is having patients have bleeding. And what does that mean? Does it really matter when there is bleeding? And I'm here to tell you that there is a very, very close association between a patient who bleeds and their demise. And it's a very complex web of not really direct causal relationship. Of course, you could bleed to death, but that's a rare event. But there are many other things that happen when a patient bleeds. And we can talk about that during the panel, but one of them is the fact that we stop their life-saving therapies that are usually anticoagulants and antithrombotic regimens, especially if they are a heart patient. And so therefore, it is really a very, very complex web. We've done a lot of work. Philippe Généreux here in ADAPT DES showed that after you send a patient home, we had talked a lot about a patient who bleeds in the hospital, but also if they bleed outside of the hospital. It's just as important as far as the hazard of bleeding and its association to mortality than if you have a heart attack outside of the hospital. So we cannot just say, oh, they just bled, we'll give them a couple of units of blood, it'll be okay. Because if you actually look at the differential impact of bleeding and myocardial infarction, you start to see that once you have major bleeding, especially when it's major, BARC 3C and greater, 3B and greater, you start to see a very, very important change in the calculus of that patient's mortality and the relationship to mortality becoming much more important, and in fact being a more common scenario than now the rare events of stent thrombosis or myocardial infarction. But who are these patients? Why are they important, and why have they been previously ignored? Well, there are a lot of different risk parameters that we can put into an equation to say this is who that patient is, and we can predict some of it. And I owe this slide to my friend Ajay Kirtane, who also says, think about that unpredictable risk. The patient who you treated was doing great and basically falls out of your office and breaks their hip. Well, you know, that happens, and that could be very, very important. The very, very important other causes. Importantly, there are so many different risk factors, and when you put it all together and you combine it all, these are the same exact patients who are also at ischemic risk. So how do we fine-tune this? That's going to be part of what we talk about in our panel. Also, it's important to note that this is not a rare issue. If you look at the distribution of bleeding risk determinants, just based on some of the risk factors that have been previously described, about 45–50% of the patients that come and have PCI are at high bleeding risk. So this is a problem that we are facing on a daily basis. The clinical data here is tremendous. I'm not here to talk to you about the multitudes of clinical trials that have been done to show now that you no longer need bare metal stents. You could shorten the duration of dual antiplatelet therapies. And even in older patients, you should never even consider a bare metal stent, because drug-coated stents and And in this scenario, a drug-eluting stent, the Synergy stent was much better, even in old patients, 80-year-olds. So that's out of the question. But let me tell you, there's a potpourri of several ongoing clinical trials. I'm involved in some, and a lot of us at CRF are involved, including Ajay Kirtane. This one is a master DAPT program. 4,600 patients are going to be looked at, and they're going to get an abbreviated versus a prolonged dual antiplatelet regimen in those patients who are at high bleeding risk. We're going to see a lot of this data coming out in the next year, hopefully in our meeting. We work hard to get all of these at TCT, by the way. There is a Zions program. This is the first best generation drug-eluting stent right now, looking at a 28-day post-stenting duration of dual antiplatelet therapies. And there is also the Onyx 1 program that hopefully will be presented at TCT. This is a randomized study with another drug-coated stent that was previously shown to be superior to bare metal stents. So this is a major completed 2,000-patient randomized clinical study. Ajay Kirtane leads this Evolve Short DAPT program with Boston Scientific, with the Synergy stent with a biodegradable polymer. So everyone's at it. Everybody wants to do something better for these patients with high bleeding risk. But the fact of the matter is that if you look at every single one of these trials, and I'm just going to flip through them for you, they all have different definitions of who these bleeding risk patients are. And there is no question that we felt, very importantly, that there was an unmet need for a standardized definition. Whenever that happens, the Academic Research Consortium gets together and tries to come up with an answer. There are other ways to identify the patients. There are right now 27 bleeding risk scores. And I hate to tell you, I'm also responsible for a couple of those. I'm going to put them out there for you. The three that are I'm responsible for the Paris one, but there are four of them here. Take a look at how these are done. Different bleeding definitions for each and every one of them to identify the thing you're trying to predict. And the external validation is no better than a flip of a coin. So these are not really that good either. And perhaps maybe because the way we are looking at clinical trials and finding risk stratification is coming up with this mean treatment effect for our patients and trying to predict that mean treatment effect. And the fact is that risk scores give us answers for these average patients, but there are no average patients. We just heard that from Stacy Rosen. There is no patient who said, here, I am the guideline, I am the risk score, and deal with it. So for that reason, we put together the Academic Research Consortium High Bleeding Risk Initiative, and you can see this incredible large number of academics and experts who gathered with two in-person meetings and came up with going through all of the bleeding rates, all of the criteria, assessing the scores, impact of comorbidities, and then coming up with a consensus that was just presented last week, hot off the press, in two presentations, both at the circulation as well as in the European Heart Journal, coming up with a definition that talks about these major criteria and minor criteria, and you must meet one major or two minor criteria, and everyone should follow those same rules so we can talk about apples and apples instead of apples and oranges if we are going to look at this. Finally, I just want to let you know that the current guidelines, you would imagine, and we just heard how difficult it is to put guidelines together, is different in the US than it is in the United States. They're looking at the same clinical data and clinical evidence, but some of this stuff in the fine tuning of how short or how long your dual antiplatelet therapies should be and how you define a high bleeding risk patient population is very, very different. We're going to discuss that during our panel discussion. Finally, because we have the resident expert here on the panel, because there are other ways to handle a patient at high bleeding risk, there are device therapies in which you can close the left atrial appendage, especially in that atrial fibrillation oral anticoagulation patient, and hopefully just get away from having to give them any antiplatelet or antithrombotic regimen or anticoagulation. And I think we're going to discuss what this means to these patients. What is is this really the way to go? Who are those patients? Who should receive this? So I hope that was okay, Irma.
More than
Sets
three.
the panel up for a very good discussion about this patient. Who are they? The high bleeding risk patients. Can we actually define them? Will we be good enough to define these patients? And now that we've defined them, what should we do? How do we design our clinical studies to go forward? And we didn't even touch the fact that a lot of these patients are not only receiving stent procedures, but they're also having valve procedures with TAVR pharmacology. So obviously, very, very important initiative. And I think we need to kind of think about how to address this best. Thank you, Nisha, for having me.
That was wonderful. Thank you so much, Roxana. And I think you did set up the panel just perfectly. I mean, I think this is the question that I was really hoping this group would be able to answer is, now say that you've identified a patient that you think is a high bleeding risk patient, how are you going to treat them differently? And how do you factor in the degree of ischemia, or where do you put their ischemic burden versus their bleeding risk? And how do you use that clinically and try to convey it to another person?
Yeah, so a very important question. And I think the best piece of this is the fact that no risk score is going to help you. You really, really need to kind of dig deeper and understand what that patient's, everything about the patient. Some of it is perceived risk that is not measured by any calculator or even a demographic. Their compliance to medication, who's taking care of them, what's their frailty index, all of those important. So putting it all together. And then I think one part, depending on whether they're having a valve procedure or a PCI procedure, I think it has to do with the complexity of the procedure and the complexity of their anatomy and their ischemic burden. One of the things we cannot do is to ration them of anti-ischemic regimens to try to prevent a bleeding event and then exposing them to horrible risk of stroke. Because if you actually ask a patient what's important to you, stroke is, they'll take a blood transfusion, but they don't want to have a stroke. So I think it's really important to kind of have that patient to doctor discussion and talking about their risks and moving forward. It's not an easy answer. So that's a good thing because it keeps us doctors in business, and there are no algorithms that work and no machine is going to figure it out for us. So we still will be in business having to actually talk to the patient.
Dr. Ng, same question. And also, how does it, how if you have a woman who you perceive as being high bleeding risk, how does that change your approach to the procedure going into it, the conversation you have with them up front, your choice of antiplatelet agent? And also, as an interventional cardiologist, what do you think about in terms of vascular access? How do you minimize bleeding rates during the procedure itself?
Absolutely. So lots of things packed into that question. I mean, The simplest from a procedural standpoint is that studies have shown that women are at higher risk of bleeding complications after their procedures, whether or not it's diagnostic, but also patients who are coming in with acute coronary syndromes who are definitely going to need some type of antiplatelet therapy or anticoagulation for their procedure itself. And so you need to take that into consideration when you're doing a procedure on a female patient, that they're at higher bleeding risk. So for those patients, I think we really need to consider doing more radial access procedures for them. Now, women, the older, frailer women who are going to benefit most from getting radial access, they're also going to be the most difficult to navigate getting that radial access. But I think we can't just shy away from it and say it's going to be difficult because you're older and smaller. I think that we have to push, and there are lots of new techniques now in order to make those procedures possible. And one thing that Dr. Mehran was saying that I think is very important is we can't be afraid about treating patients for their ischemic burden just because of this perceived risk. Right, so it's not so much just that it's oversimplified to say female patients have higher bleeding risk. They're coming to us when they're older. They're going to have more of those risk factors that you pointed out that puts them at higher bleeding risk. But we don't want to say we're not going, I'm going to take away some of this antiplatelet therapy. I'm going to take away some of anticoagulant therapy because I'm afraid you're going to bleed. And I think it really is having that conversation with the patient and being honest with them. Because, like you said, they don't want to have a stroke. They much rather, not that it's a great option, but their bleeding risk, their risk of bleeding versus a stroke, it's perceived differently by each patient.
And I think so much of the pendulum has swung even in the time since I was in fellowship, which is not that long ago, right? Was what we told everybody was that a year of dual antiplatelet therapy, then it became 6 months and now it's like, well, who knows? Maybe 4 weeks, maybe 3 months, depends. So what is the shortest that you would do, say for a stable, not ACS patient? What is the shortest duration of that you're comfortable with?
I think it depends, again, on each individual patient.
And the type of stents used.
Right, and the ischemic burden that they have. So a patient who had left main complex bifurcation stenting going into the left circ is going to be different than the conversation that a patient who has a distal RCA stent. And so the risk of taking off their antiplatelet therapy early versus late is going to be a very different conversation.
And then shifting gears a little bit, Dr. Bond, to talk about, when this is like the worst thing, right? Especially from the inpatient side, when you've just done this, you all do these fantastic PCIs, and then, 18 hours after their procedure, they have new Afib. And then what do you do with the patient who has coronary disease and has concomitant Afib, and how do you approach it?
I think from the perspective of having Afib, we know atrial fibrillation is very common, particularly as we get older. We also know that women tend to be at a higher risk of stroke if they do have atrial fibrillation. So we have to factor in the risks that come with that, and what is their risk of having an ischemic event or an embolic event, as well as what is their risk of bleeding. It's really about having that conversation with the patient, knowing that we may have just had a procedure where we need to keep a close eye on your access site, preferably, hopefully, being the radial access site. But understanding also that if we hold anticoagulation, their risk of having an actual embolic event may be very high. So we just have to factor the risks versus the benefits and have that sort of formalized conversation with the patient. I know in general, study after study has shown that women tend to have less of a prescription for anticoagulation. They're also less likely to be referred for procedures like cardioversions, ablations, despite the fact we know that they have improvement in their quality of life. So we don't necessarily want to limit the actual medications, which we know are going to be benefiting them in the long run, but we just need to have that sort of educated conversation with them to explain to them that they may be at a little bit of a higher risk of bleeding, especially in the peri-procedural or the post-procedural period.
And I think it's so varied by institution what we tend to do with triple therapy, right? So do you do dual antiplatelet therapy plus the anticoagulation? So in your experience, Dr. Ron, I know what we do at Columbia, and we sort of shy away from doing triple therapy prolonged or at all. But what is being done at different institutions?
So the new North American consensus is really giving a default therapy unless the patient has a very high ischemic burden to drop aspirin. That's a hard thing to do, especially after you just put a stent in the left main and have done all this, and you're like, okay, just clopidogrel alone. And I think everyone is testing those patients before sending them off if they're choosing to have not triple therapy. Now, in the European guidelines, their default therapy is triple therapy, but in a very short duration. So they're not buying the no aspirin because of the fact that there is a signal when you combine all of the data of the novel oral anticoagulants and vitamin K antagonists with or without aspirin and clopidogrel, that there is a signal of more myocardial infarction and perhaps even stent thrombosis. So again, here's two guidelines going in two different directions for the same types of patients, confusing the heck out of everyone. So it comes back to the physician. And I think that if I really perceived someone's risk to be very high, so someone who just had a bleeding episode, and then I was coming in with an acute coronary syndrome in which I put a stent in a thrombotic occlusive lesion, I'm going to be a little bit sort of careful about if I'm going to send them home without aspirin because they just had a bleeding episode. I'm going to check their platelet responsiveness with clopidogrel before I would send them home. So it's that kind of, one by one, case by case scenario.
Exactly. I think that happens across the board. It's just you have to individualize it to each patient. And I know Roxana, you were absolutely correct in calling Bob our expert on, Bob and I have had multiple conversations, world's expert on left atrial appendage closure, because we've had a number of conversations on how can we utilize this in these patients and so what patients do you think currently would you say are appropriate, and include the PCI ones, but
Sure.
but what patients are appropriate, and also do you feel like they're getting to you? Do you feel like these patients have access to care centers?
So typically speaking, this is not a pediatric procedure, but kind of came out as a fallback for us. But the group of patients that we are really focused on for left atrial appendage closure now in our institution, I think it's pretty generalizable. The primary group of patients are those patients with a high CHA2DS2-VASc score who have bled, right? These are the ones that the primary physicians, the cardiologists, the GI specialists, the neurologists are all sending in droves. And so those are really the bulk of the patients we do. There are three other groups that we're looking at, really in particular. One is at the other end of the spectrum, which are two at the opposite end of the spectrum. One is the very geriatric patient. And as we know, oral anticoagulation is vastly underutilized in that population for physicians' anxiety more than anything else. You have a little old lady with a walker who's falling all the time. People don't want them on oral anticoagulants. So that's one group of patients that could potentially be a very valuable addition to get a left atrial appendage closure procedure as an alternative to long-term oral anticoagulants. At the other end of the scale are these young 50-year-olds who present with, let's say, a stroke and have AFib for the first time. But meanwhile, they're still riding their motorcycles, jumping out of helicopters to ski and that kind of thing. And being on an oral anticoagulant would substantially create a problem for their lifestyle. So we've done several of those. And then I can't kind of think of the last one. Oh, the last one is the triple therapy patients. Now, Nisha and I took an initiative a couple of years ago to try to identify at Columbia patients who were coming in for a planned PCI who had a history of atrial fibrillation, who we knew were going to be on triple therapy. And we were trying to set up a trial, and it didn't actually happen. Roxana was helping us for a short time, but really to try to see if this was an elective PCI, perhaps these patients would benefit from getting a left atrial appendage closure first, and then they would not need to be on triple therapy at the time of their PCI, to see if that made a difference in stroke rate, if that made a difference in bleeding rate, if that made a difference in stent thrombosis rate in the patients who potentially were on shorter therapy trials of dual antiplatelet therapy after the intervention. So those are really, I think, the four populations of patients that we're taking care of right now.
I think one of the biggest things that we need to realize is what Bob mentioned, is that we all know that oral anticoagulation is a class 1A recommendation for stroke prevention in patients in atrial fibrillation. And yet, if you look at the population at risk and the penetration of the use of oral anticoagulation, whether it's vitamin K antagonists or novel oral anticoagulants, is abysmal, especially in the underserved patient population with multitudes of multifactorial risk factors. So if there is a way to identify these patients and actually close their left atrial appendage, I think it could be actually cost effective to the healthcare.
And just in terms of access, the DOACs have made an enormous impact on the management of atrial fibrillation. There are vanishingly few patients who are still taking Coumadin. It's really quite remarkable.
Who in this room still prescribes Coumadin?
Right, my point exactly. Once in a while. Yeah.
All the PE people keep saying that.
But the bottom line is that they are remarkably expensive, and people can't afford them. And so a lot of times people will just not take them. And so, that again is another access issue today. And cost effectiveness, when you think of the cost of a one-time procedure versus maybe 20 or 30 years of oral anticoagulant therapy, potentially blood testing, potentially hospitalizations for bleeding risks, I think it's going to work out. And there was already data that shows that over 7 years time, some of the Watchman data showed cost effectiveness compared to oral anticoagulation already in a period of time. So depending on the age of the patient, I think there's really going to be some shifts in the whole paradigm, which is already changing.